Hello, my name is Hayden McKay, and I will be presenting on my research about achondroplasia, sleep apnea, and orthodontic interventions and their interplay. This is a comprehensive literature review with myself and Dr. Joe Cheever. So, what we are looking at here, and I'll dive a little deeper into this, more of the etiology of achondroplasia and what it is, why it happens, and why it's important to our research. And so, while it is sometimes hereditary, most cases of dwarfism are actually caused by a genetic mutation. And this is why the majority of people who have it have normal-sized parents. And people with achondroplasia technically have, they have short arms and legs and an enlarged head for the, compared to the rest of their body. And hormones can be taken to help increase their height, and in rare cases surgery can help correct an abnormal curvature of the spine and bowing of the legs, which happens. So it sort of affects the bones of the body, their growth, which is what we deal with in orthodontics as well. So in children with achondroplasia, multiphase craniofacial abnormalities contribute to the airway volume reduction, predisposing to sleep distorted breathing. An MRI-based quantitative assessment allows us to appraise the craniofacial abnormalities linked to the development of this sleep disordered breathing. So we can take lateral cephalomectrograms, but that can't always be trusted with the airway measurements. So we send them for a full sleep study, and if they do in fact have sleep apnea, then that's when we can go ahead and start treating. So this happens in these achondroplastic patients due to stenosis. A lot of things happen with the neck and the musculature and the skeletal framing of the face. So the maxillary position can also be variable for really trying to figure out who has the sleep apnea and who doesn't. So these patients can live fully functional lives, though. It's not like this is a true disease. It's more of an we call it an abnormality or a mutation that can happen. There are many celebrities that have gone on to live full and very fulfilling careers. So, like I stated before, our research is not complete. We've started to really kind of compile the articles we're looking at and finding more about the etiology of achondroplasia and sleep apnea. And now later on, I feel next year will be sort of our focus into the real meat of the research, which is those orthodontic treatment modalities that we can then use in our clinical practices and make this literature review really worthwhile. So that's sort of the disclaimer. We've gone through and used many sources like PubMed and used our exclusion-inclusion criterias and found lots of great articles actually about sleep apnea being a direct side effect of this achondroplasia, and great evidence that shows more about the bone formation and details outlining the underlying causes of the sleep apnea because of their smaller faces, the stunted growth in certain places, and in the maxilla. So sort of the weakness of what I've found so far is studies are not really tailored toward the orthodontic treatments as more they are linking sleep apnea to achondroplasia. So we'd like to dive further into that, and but what we have found is that in recent studies, the potential for orthodontic interventions to improve sleep apnea in patients with achondroplasia is high, and orthodontics offers various techniques and appliances that can address anatomical and structural issues associated with both achondroplasia and sleep apnea. So the real purpose, I feel, is to make sure we can find out if these treatments that we already use to treat the sleep apnea can be then transferred to patients with achondroplasia, and if there's any problems we would run into, or if this be something we want to avoid. So that's kind of where the research is headed. So these treatment modalities, though, include palatal expansion, which we use a lot, opening up the room for more air, mandibular advancement, moving the lower jaw forward in order to create space for the tongue, which can fall backwards while you're sleeping, and just create a higher volume of airway, as well as adenotonsillectomy, adenoids and tonsils, taking those out, which I feel like people have gone away from recently, but in these patients may be of value just due to the small size and stature. There's just not space for everything, especially if they start to grow and they're taking their hormones to grow into a more full adult state. So that's where we really want to focus our future research. Again, like I said, this is our poster is not really complete because our research isn't complete, but we've included everything here that we've done so far, and we're trying to be thorough and really want I think by next year hope to have a great poster to present to you on these orthodontic interventions. And also, I think an important part of these literature reviews are to point out gaps in the research and maybe highlight a new area that could be researched by someone at the school or just someone in the field in general, to really provide some hope and promise to these patients as well with their sleep disordered breathing. So thank you again for your attention.